Welcome, everyone. Welcome to Dental CE Academy. I'm Dr. Kirsten Rowling. I'm the Chief Education Officer here, and we have an exciting program for you this evening. I do want to direct you to a couple of things. Please take a look at that red banner at the top of the screen to download the handout and CE credit instructions. This presentation is being recorded. This is January the 24th, 2024. So if you're watching this presentation at a later date, to receive the handout and quiz, just scroll below the video player to the instructions section. Number 2 will be your handout, and number 3 will be your quiz. If anyone needs assistance, please let us know by tapping into or typing into that chat area. Also, in the instructions area of our chat, you'll see an orange box with further instructions on how to download the handout. And there is also a direct link if the banner does not work for you on your device, or a couple of devices that may be the case. All right, let's go ahead then and get started. And again, welcome everyone to Dental CE Academy this evening and our presentation. And we have Dr. Colby here, who's going to be presenting this course. Before we get started, housekeeping, everyone always wants to know, how do they get CE credit? So following this 1-hour continuing education program, you will have the option to stay for a few minutes and learn more about this technology and TriAgenics. So I hope you will stay on because it is game-changing technology. For those of you that want your quiz, you can log off at any time after 6 o'clock Pacific time, and you'll be redirected to the quiz. You can also stay on. We'll be sending you a reminder email as well. And let me go ahead now and introduce you to our speaker this evening, Dr. Leigh Colby, Director, President, and CEO of TriAgenics. From 1995 through 2015, he was the founder, CEO, and sole shareholder of Oregon Dental Care, a successful group dental practice in Oregon that delivers high-quality patient care in a zero-defect operating environment. Oregon Dental Care was then acquired by Interdent in the late 2015, where he served as the managing clinical director. Prior to starting Oregon Dental Care in 1995, Dr. Colby was involved with 3 high-tech startups that all remain in successful operation today. In 1980, he was the principal founder of Laserdyne Corporation and wrote the groundbreaking specifications for the successful high-resolution beam director general-purpose CNC laser machining system. The beam director system remains the #1 selling general-purpose laser machining system worldwide. In 1984, he assisted the founder of Cyber Optics Corporation in defining their initial product specifications and market applications to establish initial distribution channels for their unique high-resolution, non-contact laser gauging and automated inspection products. Dr. Colby worked with Cyber Optics to develop and implement a marketing plan which drove initial product sales and propelled them to a market leader where they remain today. In 1986, he teamed up with 3 PhD-level biochemists as their vice president of marketing to define and establish their first commercial operations for Surmodics, Inc. His 10-year effort there ultimately resulted in revenues approaching $100 million annually for the use of PhotoLink high-reliability biocompatibility enhancement technology on a variety of widely recognized implant and disposable medical devices. Surmodics remains a publicly traded operation. Dr. Colby has earned his MBA degree from Northwestern Christian University, DDS and BS degrees from the University of Minnesota, a BS degree from St. John's University, and is a certified Lean Six Sigma Master Black Belt. So I welcome you here today, Dr. Colby. It's truly an honor to have you on our platform. I will turn this over to you. Now, for anyone who has questions, please go ahead and type them into the chat area. We're going to be checking in periodically with those questions. I will alert Dr. Colby, and then we'll also have a Q&A towards the end. So thank you again for being here, everyone, and thank you, Dr. Colby.
It's sure a pleasure being here. I hope you find this very interesting. It's a unique treatment modality that is used in the cancer treatment area, not in dentistry. And you'll find this really quite fascinating. And our goal in adopting a unique treatment methodology like microwave ablation is to predictably induce complete third molar agenesis. And the operative word is predictable. Our goal is to induce complete molar agenesis with greater than 99% success, and we've demonstrated that in animals. I'd like to show you how it works, what the history is behind this. And again, please shoot questions as you have them. I do want to disclose that I'm with TriAgenics, and TriAgenics has privately funded most of the research work that I'm reporting on this evening. A quick overview of what we're going to talk about. Historically, we're going to just do a brief overview of approaches for third molar management. We're going to talk about the 3TBA, third molar tooth bud ablation, clinical goal, which is ideal lifelong outcomes with the least surgical risk. And I'll define what ideal means. And this is a fully guided approach. And unlike placing dental implants, this is multidimensional. But you have to control all the dimensions of this process in order to obtain ideal outcomes. We'll talk about our animal studies, how we perform them, and then we'll take a look at what the outcomes were. And then we'll talk briefly about human clinical trials. Historically, third molar management has been a real lightning rod in the industry for decades. Whether or not to monitor and treat for patients over age 25, which has the highest risk for surgery and really the worst outcomes with age. The alternatives have been prophylactic extraction, age 16 to 25. There's moderate risk, moderate outcomes. And then you can go earlier with prophylactic germectomies before the roots form at age 12 to 16, much lower surgical risk and better outcomes. But the 3TBA clinical goal is to have ideal lifelong outcomes with the lowest possible surgical risk. Let me define what ideal means. Those patients that never form third molar tooth buds or third molars have none of the problems that the rest of us have. And I say the rest of us because I had my third molars out second year of dental school. Was not the way to learn about osteitis, but it was a good learning experience. So our ideal outcome is that when we perform third molar tooth bud ablation in a fully guided environment, we have the lowest risk and the patient outcomes are the same as if though they naturally would have never formed the third molar tooth bud. That's our goal. All our engineering work is directed at this singular goal. So historically, it's been demonstrated repeatedly that early intervention is safer and effective. The American Academy of Oral and Maxillofacial Science has a third molar white paper published in 2007. And their conclusion was early third molar removal is associated with lower incidence of morbidity and less economic hardship for the patient. And this is an interesting paper where they compared germectomy to surgical removal through a large patient study. And their conclusion was that waiting to remove third molars until the roots form subjects patients to unnecessary pain, far more complex and costly procedures with higher risk for post-op complications. That was in 2017. There was an interesting study that you may not be aware of that was published in 2021. I like this study because they followed 6,000 patients, mean age 25, had 6,300 surgeries to remove over 15,000 third molars. And what was interesting was they followed up with the patient at 3 days and then 10 days to find out what the complications were. And what their conclusion was that those patients over age 25 had a lot of problems. And they recommended, in what I think is probably one of the largest third molar studies, they recommended that timely removal of third molars before the age of 25 would lead to lower morbidity and reduced nerve complications. The AAPD reference manual of pediatric dentistry for 2021 and 2022 recommends that treatment of third molars should be provided before pathological conditions arise that might adversely affect the patient's oral health. And they recommend a decision to remove by age 25. And they made the comment that post complications are low when performed at an early age. All the data would seem to support that. So what about intervening before tooth formation occurs? The Ricketts reported, I believe he was an orthodontist in the San Diego area. He recommended third molar tooth bud mechanical enucleation. Go in and surgically remove the third molar tooth bud. And he reported no complications, but it's pretty invasive on a 9-year-old kid, and it really is dependent on the operator skill. Gordon and Laskin, 2 oral surgeons in the Chicago area at that time, performed the first tooth bud ablation procedures. They used cryoablation. They placed it by hand, so it was not a guided procedure. They did not appear to have a calibrated procedure. They reported no safety issues, but they had inconsistent outcomes. And they saw that a significant portion, as high as half the premolars in a dog model, resulted in at least partial inhibition of crown formation, but it wasn't complete. They saw no problems with the adjacent teeth. So there were no safety issues, but they had inconsistent outcomes. And finally, Silvestri, who was with Boston University, attempted unguided laser and RF ablation of tooth buds. The procedure was performed in both a dog and a rat model and occurred before the tooth bud was detectable on any x-rays. So there was no ability to localize the tooth bud. And he reported inconsistent outcomes, but there were very serious safety issues. He used the laser or the electrosurgical energy to actually transmit energy through the oral mucosal tissue to an undefined target, and the adjacent second molars were sometimes affected. And in the maxilla, there were deformed bone structures. So it was really an uncontrolled process, inconsistent outcome, and I would say serious safety issues. So a good summary of the summary of unguided procedures. There were safety and issues or efficacy issues reported when the procedure was unguided. Based on my experience in the technology that I've been involved with, the poor outcomes occurred because there were 3 critical process variables that were either not understood or not controlled properly. And one is the ablation positioning control, and we'll talk in detail about each of these. ablation position control, ablation physics control, and ablation volume control. In order to have predictable, and again, the most important word in this procedure, to have predictable outcomes, you have to control all three of these. So the fully guided 3TBA rationale is really quite simple. It's driven by anatomy. And if you look, I'm assuming you can see my cursor. You can see a 5 to 10 millimeter separation between the superior aspect of the mandibular canal and the third molar tooth bud. We surveyed over 1,000 cone beam CT scans, and the average separation was around 6 millimeters. We did not see any third molar tooth buds that were closer than 3.5 to 4 millimeters to the inferior alveolar nerve. So that nerve separation is a huge safety issue. And second molars, adjacent second molars, are always fully, the crown is always fully formed when you can detect the tooth bud. It's reported in the literature, and we noted that again in our survey of over 1,000 cone beam CT scans. The root tips of the tooth may not be fully formed, but on the second molar, but the crowns were fully formed. And from a procedure safety perspective, there is no ability in the technique that I'm going to show you to affect the adjacent tooth. And finally, the probe is inserted so that the center of ablation is put into the center of the tooth bud. And this is a critical step. And I'm again assuming that you can see my cursor. We find the middle of the tooth bud three-dimensionally, and we put the center of ablation, which is not necessarily the tip, and we put that in the center of the tooth bud. We have a fully encapsulated treatment site. And that step eliminates almost all post-op complications. There is no ability for osteitis to occur, dry socket to occur with the 3TBA procedure as we are performing it. So let me summarize the multidimensional aspects from an engineering perspective. Ablation positioning control is plus or minus a 0.5 millimeter planning resolution. We use modified dental implant technology, and we call our guides 3TBA guides, and we maintain the positioning of the center of ablation in the center of the tooth bud. And a critical aspect of what we do is the ablation physics control. We had to develop a unique technology for this. I should comment that conventional laser and medical microwave ablation technologies were a disaster. We were looking for an off-the-shelf solution. And when we used conventional microwave ablation technology that was used for tumors, for instance, they were surprisingly inadequate, and lasers will not work. The heat distribution is inappropriate. It will char the tissue, and we don't want that. I'll explain more about that as we go on. And once you control the first two, then you can control the ablation volume. And what we do is predetermine the location of the margins of the ablation volume. We position them, and then as we're delivering the thermal dose, small thermal dose, we use real-time feedback to make sure that the thermal dose is being accurately delivered. And the key thing about microwave ablation technology is that we can deliver targeted zones with no significant collateral damage. We can really dial in our margins, our diameters to within 1/10 of a millimeter. Very precise procedure. And this has not been reported elsewhere in the medical tumor ablation industry. So let's focus just a little bit. Ablation positioning control is critical, as you can imagine. And in these slides that you see here, and if you don't recognize the anatomy, don't be surprised. This happens to be a pig, which we did all our human studies on. The reason we use the pig model is that the healing mechanism post-ablation is the same as in humans. And that's why pigs are used in a lot of tumor ablation models. And so we center on the axial view, in the coronal view, and then in the sagittal view. And then we design a surgical guide that will deliver that. A key thing that we have spent a lot of development time on is to limit the peak temperature. The amount of energy we're putting, I'm holding up my cell phone here, and the amount of energy going into the tooth bud is far less than what your cell phone outputs, it transmits. If I could connect directly to my cell phone, I could do this procedure because your cell phone is transmitting microwave energy. And what this shows on the upper left is that there's steam being generated. These are 10-degree isotherms starting at 50 degrees centigrade. And on the innermost isotherm, where it looks ragged, you can see that it's above 100 degrees C. Steam is being generated. That is commonly done in large tumor ablations. They literally drive the water out of the center of the tumor in order to get the margins to treat the patient. We're dealing with 5-6 centimeter diameter tumors. And we do just the opposite. We do not want this temperature to go above 80 degrees C. And so in our technique, we have to distribute the microwave energy in such a way that it fans out and gently warms the tissue, even though it's less than 5 watts, but do it without charring. Tissue charring will lead to really an unpredictable healing process. But the most important mechanism that occurs in the ablation is that the outer periphery of the ablation is a fairly low temperature, and the tissue death occurs by thermocoagulation. It doesn't occur because the temperature is so high that it instantly kills the tissue, but rather it's thermocoagulation. And what that is, the mechanism is that the capillaries become clogged. It literally coagulated, and it starves the inner tissue from oxygen and blood flow. And the World Health Organization refers to this as a low temperature ablation. And this is similar to what's done for cervical cancer tumors. But a key thing that we had to deal with was ablation shaping. It was amazing how truly barbaric the medical ablation technology was. And this picture on the far left shows our target volume. And in order to get the width that we needed, we had to extend far beyond the target diameter. And where my cursor is, this would be the patient's oral mucosal tissue in a 9-year-old. And that would result in a burn on the patient. And when you have burned tissue, it's avascular, and that would increase the odds of infection. And we could not live with that. We tried, and this is at 2.45 gigahertz, which is what most medical ablation technology operates at. So we were recommended to go to a higher frequency. This happens to be at 8 gigahertz. And the ablation zone looks better, but it's still teardrop shape. Again, where my cursor is, the patient would have burned gum tissue, which would act as a nidus for infection. What we had to develop, and it was the most difficult part of our development process, was an antenna design that would result in a true spherical zone of ablation. And this has not been reported elsewhere in the medical ablation industry. So it was purpose developed for third molar tooth bud ablation, and works really quite well. And to show you what kind of control we have over ablation zone shaping, we can make the ablation zone, this is the ablation probe, we can make it 1.4 times wider than it is longer. That has never been reported in the medical literature. We use spherical, and we can also make it oblong. So we have complete control over the shaping. And once we have shape control, then we can deal with the next issue, and that's having a fixed center of ablation. What I'm showing down here where my cursor is, this is a New Wave PR probe. It's one of the best tumor ablation probes on the market. This is from New Wave's website. And you can see where at the start, where my cursor is, that's where the center of ablation is. But what happens as the probe heats up, the center of ablation effectively migrates up the shaft. And the claim to fame for the PR probe is that it doesn't extend beyond the tip, that they have control to avoid damaging adjacent critical structures while doing tumor ablations. But if you think about that in a CT guided procedure with an implant surgical guide, if you've got a center of ablation migrating up the shaft, where are you going to position the probe to begin with? And we found this was totally unacceptable. So what we did was develop a unique technology where the center of ablation is known to within 0.5 millimeter. And then as the ablation process unfolds, the center of ablation remains fixed on the shaft. So when you insert the probe into the center of the tooth bud, you are effectively radiating out from the center. And that is how we get predictability in our procedure. It's a very critical aspect of how the third molar tooth bud ablation technology works in a fully guided environment. Once you have a fixed center of ablation and you have the shape control fixed, then you can control volume. And we prescribe the zone of ablation to fit inside the tooth bud with 210. We measure the maximum diameter of the tooth bud. We place the center of ablation in the center of the tooth bud, and then we ablate 2 millimeters in diameter greater than the maximum diameter, and it works really good.
Dr. Colby, we do have a question for you from Maggie, and she wants to know, how is the surgical guide fabricated? Is it CBCT or ICAT? What are you using?
Fantastic question. For all our animal studies, we use cone beam CT imaging, and we would take an impression. You can use obviously a PVS impression or a digital impression. And then from there, we fabricate the surgical guides, actually design them on screen. So we have the center of ablation in the center of the tooth bud. We 3D print. So this is the same steps you would take for fabricating an implant surgical guide. There is no difference. And I'll be able to show you a surgical guide later in the presentation. Excellent question. Keep the questions coming. So if you already know how to use an implant surgical guide, you've already been trained on how to do this procedure. Oh, let me go back. So we then have the ability to intentionally underablate. We can intentionally overablate. And let me comment on both these. When you overablate, you get a completely successful procedure. Trust me, there is no ability for the tooth bud to produce any tooth structure whatsoever. But if you intentionally underablate, what you end up is ablating the central portion of the tooth bud. And that's the area where the tooth bud is programmed to produce dentin, and you convert the tooth bud to a deciduous tooth, producing a deciduous tooth. And I'll show you some interesting x-rays on that. All the oral surgeons that have been involved with our project say underablating is a successful procedure. But our goal is to intentionally ablate so that we have 1/10 of a millimeter on each end of the tooth bud at their longest diameter. And we just effectively destroy 100% of the tooth bud tissue, including the follicle. Let me comment about the fully guided 3TBA in a porcine model. We use the pig model because the animals have a similar healing pathway biochemically to humans. They're excellent to work with. At the age of the animals we work with, you can see results in a matter of weeks, and I'll show you x-rays on that. They can be a tough model to work with because they grow 1 pound to 1.5 pounds a day. So long-term studies become really difficult. The animals will get up over 300 pounds in a long-term study. So you can see here we seat the tooth-supported 3TBA guide. This is a quadrant guide. If we could have made full arch guides, we would have done that, but it was just not possible because of the V shape of the animal, the jaw of the pig. Their snouts are growing so fast. And then in the porcine model, an osteotomy is absolutely necessary. We went through the anterior of the ramus of the mandible. We could not go in medially or laterally unless we could go in laterally in a dynamic navigated procedure, but we could not reach the tooth bud medially, even though it's just beneath the surface of the oral mucosal tissue. It's unique to the animal model. They have very long jaws, and they have the biggest tongue. It's just, they're impossible to have a medial aspect. But you seat the guide, you make the small quick punch, takes about 5 seconds to make the punch through the ramus of the mandible. And then you position the 3TBA handpiece, and it's very simple. You slide it in until you hit the stop on the guide. It is that simple. And then you deliver the ablation cycle. Our typical cycles were 30 to 60 seconds. Matter of fact, we saw no ablations longer than 60 seconds. In humans, it could be as short as 20 seconds because we can find the tooth buds at a slightly earlier stage. And I'll show you what the ablation looks like. Then you remove the 3TBA handpiece, and the procedure is done. It really is that simple. So the operator's responsibility is placement of the 2 millimeter diameter probe, much like placing the initial bone burr. You get that into place, and you go until it stops, and the procedure is done. Let's take a look at the animal trial results.
Dr. Colby, you have one quick question here.
Yes.
How does the temperature vary with humans versus pigs?
There will be no difference. And the reason why I say that with confidence, the thermal dose with microwave is based on water content. And the water content in a human tooth bud is the same as in a pig. Yeah,
okay.
It really is the same.
That's fascinating.
Yeah.
I want to remind everyone too that those of you that jumped on a few minutes late, you do have a handout and the CE instructions. Please tap on that red banner at the top of the screen and refer to the instructions. You'll need those. And I'll go ahead and turn it back over to you, Dr.
Great questions. I really appreciate you asking them. We use the upper arch. We use the maxillary tooth bud opposing as our unablated control. And here you can see the third molar tooth bud on a pig. It's very small. It's very different than in a human. And we had an immediately adjacent second molar that was forming. So this tissue right here is very sensitive to heat. And we also had the inferior alveolar nerve less than 1 millimeter away. The cortical bone thickness was less than 1 millimeter from the tooth bud. And the reason why I point that out is that we measured on every animal pre-op, we measured lip sensitivity, upper and lower arch. And then after the procedure, we measured again. Each time we saw the animal and CT scan them, we checked for lip sensitivity, and there was never any evidence of any neurological impairment. You have another question?
Another question from Mindy. What type of sedation is needed for humans?
In our proposed clinical protocols, we need only local anesthetic. The third molar tooth bud itself does not have nerve endings inside of it. So pain control is strictly superficial over the cortical bone, and that would be the oral mucosal tissue. The oral surgeons that we work with indicate that a quarter to a half carpule of local anesthetic on the buccal, quarter to a half carpule on the lingual is all that's necessary. It's strictly soft tissue anesthesia over the targeted tooth bud. It's an excellent question.
Question from, I believe it's Thayar. Can you do this procedure on maxillary third molars as well?
We have a pilot project, a pilot study planned, and I will, maybe we could jump out for just a second, if that's okay.
Sure.
It's a very important question, because on the mandible, what you can see is there's a tiny hole added here. Let's get the lighting right. Yep, you can see the small hole here that was added, and that goes through the center of the mandibular third molar tooth bud. And on the upper arch, axis is very different. The third molar tooth bud, and if you look close, you can see where we added a hole there. You run your finger up along the sulcus, and you actually can palpate the third molar tooth bud. And at this stage, before any tooth structure is present, that tooth bud is spongy and the bone is very thin over it. So access on the upper arch will be lateral, and we are working with oral surgeons on this. We may need to have a different microablation probe for lateral access, but we have a maxillary third molar tooth bud pilot study that's planned. But when we introduce our product, it'll be focused on the mandible, because when you run your finger down the central groove, you're actually pressing on the dome of the third molar tooth bud. It's just maybe 1.5 to 2 millimeters below the surface. And then you've got the surgical guide, and you actually slide it until it seats. The bone over the tooth bud is also spongy on the lower, but it will likely need to have a small osteotomy to punch through just in case. But both are readily accessible. But the maxilla will be a lateral approach. Good question. Getting back to the slide, we use the upper arch, opposing maxillary control, and then the lower arch, you can see the ablated or our target. And this is 1 day pre-op, and this is 7 days post-op. And in the thin cortical bone that's over or surrounding the tooth bud, you can see just the outline of where the bone growth has been disrupted. And yet on the upper arch, you can begin to see the cusp tips form. And that's why the pig model is such a good model. These animals go from 7 weeks of age to 8 weeks of age, and you can see the upper arch and the lower arch form tooth structure if you haven't completely ablated. And on kids, the peak of the curve will be about 9 years of age for treatment. I know that'll be a question that'll be asked. And here we are 4 weeks post-op. You can see the upper arch, unablated control. The pig is 11 weeks of age. On the lower arch, there is no sign radiographically, no sign of the tooth bud. It's completely filled in, at least at the radiographic level. And let's take a look at longer term. And you again, upper arch, unablated control. This is 1 day pre-op, so you can compare. 8 weeks post-op. This is 1 day pre-op. You can see the targeted tooth bud. And this is 8 weeks post-op. We went out close to 18 weeks on this, and there was just nothing to report from both histology and radiographic imaging. There was just nothing to find. So most of our studies were terminated at 4 weeks because there was no need to extend the study. But what's interesting is what happens from a visual exam point of view. This is an immediate post-op. On the pig, you can see the puncture, and that's all it is a puncture. There were no sutures placed. We had no signs of infections. And then this is 1 week post-op. We could not find the insertion point for the third molar tooth bud ablation probe. And on histology, the histopathologist could find no evidence that the probe had been introduced through the oral mucosal tissue. You have a question?
Dr. Colby, from Gary, what is the limit of development of the tooth bud for the ablation to be successful? Any calcification as a result?
Yep. We can have minor calcification of the cusp tips evident. And the reason why it works is that it's real interesting. Remember that this is a microwave thermal ablation process. So the mechanism of action is that we are vibrating water molecules, just like your home microwave. And we're gently warming the tissue. And when the microwave hits the enamel that might be present, it goes right through it. There's no water, so it's radiolucent to microwave at the frequency we're working at. It has the presence of small mineralized tooth structure has no impact. Once the cusp tips become connected, then we physically can't get the probe into place, and that limits the procedure. It's a really good question.
Question here, any risk of cyst formation in the area?
We did not see that, and we think there is no risk of cyst formation. And the reason why I say that, we look for any signs of the epithelial rust cells on histology. And what we saw was complete bony ingrowth with no remaining detectable tooth follicle tissue. And that's a real important question. And that is why we choose to slightly overablate the tooth bud. We want to make sure we include 100% of the follicle in the ablation process.
Dr. Colby, we have a couple of device-related questions. One is, where is this in the approval process? And the other is, do you have a projected approximate cost for the required equipment to be able to offer this treatment modality?
Yeah, that's actually in my presentation after the CE course, but I can summarize it. The microablation device itself, which I have and will be showing as part of the continuing ed class, I've got an early stage device in hand. The final will be smaller than this. That will list for about $15,000. And then the third molar tooth bud ablation guides will be $350 per treatment site. And the probe is the disposable probe is included in that cost.
This is from Rebecca. One wonders the effects our cell phone held to our head, if this was very small dose, will coagulate the vessels in a tooth bud.
I'm sorry, could you repeat that?
Sure. One wonders the effects our cell phones held to our head, if this very small dose will coagulate the vessels in a tooth bud.
No, the answer is no. It will not. The cell phone will hit. This is non-ionizing radiation. It's a purely thermal process. And the way your antenna is designed in your cell phone is to scatter the energy. And in our case, we designed the antenna to actually concentrate it. And I'll show you in the live ablation what that looks like. This is a really good question, though. I could do this procedure with my cell phone if I could tap the power. So this is what visually what we saw in all the animals 1 week post-op. And again, on histopathology, we actually section these sites to look for the insertion point, and we could find no evidence of any disruption of the oral mucosal tissue or the tissue immediately adjacent to the tooth bud. And we have a lot of histology, and this has been, we have 2 articles where this has been reported on in the Journal of Oral and Maxillofacial Surgery. And if anybody's interested, I can send you those articles, but this is where my cursor is. This is the cortical bone of the, in the pig model. And this is the site of the third molar tooth bud right in the center. And you can see the ablation zone. This is at 1 week post-op. You can actually use differential staining to then determine the true extent of the ablations. Very small. And then 4 weeks post-op, this is a remnant, non-vital remnant of the tooth bud, all that was remaining. And there's a lot of new medullary bone ingrowth occurring. And at 8 weeks, it was all bone. There was nothing to be seen. And we expect to see the same on 9-year-olds. And let me summarize our animal studies in the form of a dose response study, because there's a lot going on in this graph, but it tells a great story. When we prescribe 100% ideal dose, and then again, that's 0.2 of a millimeter bigger than the maximum diameter of the tooth bud, we had 100% success. And this is just one study, and we saw this across hundreds of ablations. There was no detectable tooth structure. And then our control, of course, is no ablation. And we had 100% developed tooth structure, as you would expect. And as soon as we went down to 63%, about 2/3 of the planned dose, we started to see trace levels of enamel formation, no dentin. And we lower, when we get below 50%, the odds of tooth structure forming really approach 100%. Here, when we're at 30% of our target dose, we had 100% of the tooth buds forming enamel, but not dentin. And I mentioned what happens when we intentionally underablate. We ablated. This is 1 day pre-op. This is 4 weeks post-op. And we intentionally underablated this tooth bud. And at 4 weeks post-op, we started to see enamel formation. And at 7 weeks post-op, you can see the enamel shards getting larger. And this was the best image we can get on this CT scan. But at 16 weeks post-op, the enamel portion of the tooth structure was exfoliating. There was no dentin structure whatsoever. And when we talk to oral surgeons about this, they say that most of the risk in removing teeth, especially third molars, is in the root structure. And if there are no roots, then the risk is essentially mitigated. And these enamel shards simply exfoliate. So it behaves just like a deciduous tooth. Our goal is to completely ablate the tooth bud and have nothing exfoliate, but this is what happens if we get partial tooth formation. So we have conducted a mock 3TBA study. We had patients that had, in order to be in the study, they had to have third molar tooth buds. And you can see on these 3TBA guides, we've got 3 access ports to reach the center of the tooth bud. The 3TBA handpiece had the tips cut off them, so they weren't actually penetrating the gum tissue. They were just barely making contact. And the study question was a lingual approach better than a buccal approach, or would a straight-on approach work? Did we have any mechanical interferences with the cheek mass, opposing teeth, tongue? And the oral surgeons involved with the study concluded it did not matter which angle we came in from. Typically, the bone is very thin, sometimes non-existent on the lingual, but there is the lingual nerve there. So we will probably favor a straight-in approach or a buccal approach for most of our protocols, but the surgeon can specify which angle they want. And you asked about where we're at in the process here. We expect to have feasibility trials ongoing shortly. We're actually meeting in the next couple of weeks to prepare a submission to an IRB. We have a group of oral surgeons that are waiting to conduct the feasibility study, and they view this as a minor risk procedure. They've had a chance to handle the equipment, and then we will undergo pivotal trials. And I'd like to point out we are not required to have these human clinical trials for obtaining FDA approval on our equipment because we're pursuing a 510(k) approval. And we will document 4 and 12-week post-op imaging. And we expect at 12 weeks that there will be no sign of the tooth bud. And the best way to view this is a pediatric extraction. We expect the kids to respond like kids do. They heal fast. And we expect complete bony ingrowth at 12 weeks post-op. So what I'd like to do, this is always risky, doing a live demo, but I'd like to actually show you what the ablation looks like. So bear with me. I've got a makeshift platform here. And what I have is the third molar tooth bud ablation generator. And yes, you can see that good. And I will turn this on so you can appreciate how this works. We will ship with the surgical guide and the disposable handpiece an NFC card. It will have the patient's name on it. This happens to have mine on it. And you lay this on top of the device, and you can see that my name popped up, and it will have the correct thermal dose. So we determine the ideal thermal dose in our facility, and that's based on the animal studies. And we have this is a coax cable. We've got a disposable 3TBA handpiece. It simply clips on. And it's designed so that it rotates just like a handpiece that you're used to. It very quickly disconnects. And then what you do is you pick the tooth bud you want to treat. And what I have here is, let me get this untangled. There we go. I have some pork loin, and you can see I've done a few test ablations. And I'm going to get the ablation process started. Now, we go here. Okay, I'm going to pick the tooth bud that I want, and then you step on the pedal. And so this is actually transmitting microwave energy now. That's enough to do the ablation. I'm going to show you how low power it is. I'm going to slide it across the back of my hand, and I can barely feel any warmth from the ablation itself, from the probe itself. And yet if I hold it up close against the, I'm going to try to get the lighting right here. And if you look close, you can see the zone of ablation developing. Now let me move that around. Let me move it here. I think you'll be able to see it better here. And you can see the zone of ablation forming. And there you can see I have this set for a minute, but at about 20 seconds, you can see the small spherical zone of ablation. If I were to slice this, it would be hemispherical, and which is what we want. And again, the power is very low, less than the power of your cell phone, but the way it concentrates the energy, you can slide it across the back, and it's not warm enough to harm me. But if you hold it stationary, you end up with ablation zones that look like that. And we can dial in the zone of ablation to within, again, a tenth of a millimeter, 0.2 of a millimeter longer than the maximum diameter of the tooth bud itself. I'm going to set this back down. Okay. All right. And then when you're done, you simply remove the microablation probe, and this gets thrown in with the sharps. Questions?
So we have some amazing questions here. Let's start at the top where we left off. From Wendy, patients will of course ask, is this recognized treatment for insurance coverage? She goes on to say it's not her focus, but it may be theirs.
Yeah, no, it's a valid question. There are no CDT codes for this. I've been to the ADA Code Maintenance Committee twice, and until we're in humans, they cannot issue a code. I've talked with people at the executive level at the American Academy of Oral Maxillofacial Surgery and the American Academy of Pediatric Dentistry, and they have offered to help us get CDT codes issued on a timely basis. Real important question. We intend to have complete coverage, but I'd like to remind everybody that most insurance doesn't cover orthodontics, and yet patients do what's right for their kids. Every parent that was involved with our pilot studies said they want their kids to have this treatment. They did not want their kids to go through what they went through. So.
Courtney wants to know, from an airway perspective, would there be any effect on jaw growth from eliminating tooth growth?
Well, if that were true, then we would expect to see jaw differences in those patients that naturally don't form third molar tooth buds. And to my knowledge, and believe me, I've researched that question extensively, the answer is we do not see any difference whatsoever.
Bethany, if the ablation were to be unsuccessful, how soon would you know and would you be able to retreat?
Oh, that's an important question. We think everything we do in our product design is reliability, and we've got a feedback control loop that's actually measuring the energy going out the tip. That's one of the unique features of a microwave ablation. You can tell how much energy is being injected into the tissue. But having said that, we think that if there needs to be a retreatment, a 4 to 6 week post-op PA radiograph will show whether the treatment was successful, and we can retreat then. But the real honest answer is we don't know, and we honestly don't know. So the goal is to get it right the first time.
What is the projected date? This is from Thayar. What is the projected date of this technology available to oral surgeons? Can a general dentist also perform this procedure?
Well, we believe that we will have FDA clearance by mid to probably by the end of second quarter or in third quarter of 2024. We are marching towards submitting our 510K application with the FDA. We're several months away from submitting that application. Regarding availability, it is our intention to go out through the oral surgery community to begin with. They are inherently trained in this type of technique, but it will become eventually available to GPs and pediatric dentists. Any dentist that's placed an implant is already trained on how to do this procedure.
We have reached the top of the hour, Dr. Colby. I would like to go ahead and transition to your 30-minute presentation following here and encourage everybody to stay on, not required for CE credit. Here is your contact information if we did not get to your questions. There are quite a few questions here that are product related, and I think you want to stay on to know more about TriAgenics. So let me go ahead, if you don't mind, Dr. Colby, we'll go ahead and we'll transition to the next portion here.
I do want to thank everybody for taking the time to come.
Absolutely. And we thank the great questions that were asked because they were very, very important to the program. Excellent program. I do want to remind everyone that we have a banner at the top of the screen to learn more about TriAgenics stock offerings. We're transitioning now into technology and device-related information here. I'm going to play a video for you, and then we're going to have Dr. Colby take over from here. Dr. Colby, go ahead and mute your mic just in case we get some reverb here.
Good point. Over 85% of all wisdom teeth will eventually need to be removed. Chances are you already know that wisdom teeth extraction is inconvenient, expensive, and painful. TriAgenics has developed a surgery-free way to stop wisdom teeth from ever forming. We do this with a gentle 1-minute treatment called 03TBA. With our first 7.5 million raised, we finished product development, and we experienced a 100% success rate at blocking tooth formation in all our animal studies. Every year, 10 million wisdom teeth are removed in the US. Not only does it cost around $500 per tooth, but this invasive surgery requires anesthesia, and it results in an average of 2 to 3 days of absence from work or school. Unfortunately, wisdom teeth that aren't removed often cause serious problems. More than 80% of wisdom teeth are impacted, they cause infection, and they cause damage to other teeth. I was a practicing dentist for more than 25 years. This experience, combined with my roles of VP of Business Development at a medical technology company, as well as a founder of a high-tech company that was later acquired, positioned me to develop a far better treatment option. Our 03TBA device works by gently warming the tooth bud from the center outwards with the same technology commonly used for removing tumors. Kids aged 6 to 12 will be able to have this treatment right in their dentist's office with no general anesthesia or no IV sedation. There are no incisions, no sutures, no bleeding, no painful recovery time, and no need for opioid prescriptions. Our kits will cost $350 per tooth bud.
I invested in TriAgenics for 2 reasons. The concept is solid, we're avoiding surgery to remove a patient's wisdom teeth, and the people behind the concept are honest, straightforward, and get the job done. I see the 3TBA procedure as the standard of care moving forward for removal of wisdom teeth. It's a good time to invest in the company because we have had 100% successful trials and we're rapidly moving forward with those human trials this year.
What TriAgenics is working on is actually pretty miraculous. I'm very excited. I was telling my husband this morning, I said, when it comes to market, we are taking this small child and this small child and we are doing this.
Now we're raising funds for the next phase of our development. This year, we aim to seek FDA approval and scale up our manufacturing. We have 13 US patents and believe that we have an outright lock on this market in North America. We believe we've solved one of dentistry's most long-standing problems by preventing these troublesome wisdom teeth from ever forming. This is your opportunity to invest in a revolutionary technology that has the potential to disrupt an industry worth billions of dollars. Please join us by investing in TriAgenics.
We're going to need you to unmute.
Okay.
Go.
You can hear me now?
We hear you perfect.
Okay. Let me talk about the key problem that TriAgenics is going after. It's not just stopping wisdom teeth from forming. It's the key thing we're going after is developing a surgery-free way to eliminate the complications and the recovery issues associated with third molars. There are lots of studies out there that show patients and their parents for young adults miss an average of 3 days of work or school. Roughly 15 to 20% of those require unscheduled treatment for infections or dry socket. Pain medications as a measure for quality of life are generally needed for up to 7 days. The United Kingdom's website, the National Health Service website, reports that it can take up to 2 weeks to recover from having wisdom teeth removed. But the issue that we're going after, beside eliminating the post-op complications centered around recovery, is completely eliminating the potential for lifelong complications. So our solution, as I've shown you, is a fully guided procedure where we control the zone of ablation, the diameter, we eliminate the tooth bud, and you've seen it's minimally invasive. We believe that no sedation will be required, just local anesthetic. If there's a behavior problem, then an oral surgeon or a pediatric dentist may need to be called in. But it really has been designed for in-office delivery by all dental professionals. And having delivered more than 200 live animal ablations, I can tell you that this procedure personally is faster and easier to deliver than a one-surface composite restoration. I saw all the kids in our 6-doctor group practice, and you have to know what you're doing to place a composite. With this, it's much simpler. The kid can be fairly mobile, and we can still do the procedure. Our mission is to make 3TBA the standard of care by 2030. And we think we're going to be successful in doing that. We have hundreds of dentists contacting us every month asking about availability. We have large DSOs that have asked us to come in and start training on this. But our key strategy, and this underlies everything we do at TriAgenics, is to consistently deliver greater than a 99% success at blocking wisdom tooth formation with zero long-term side effects. And I've highlighted zero. Everything we do is engineered for zero long-term adverse side effects. That is really what drives us. So the patient benefits, you can imagine them as a practitioner. Obviously, we eliminate the wisdom tooth extractions, but it's a very short procedure time. As I mentioned, it's quicker, it's faster than placing a third molar, a molar restoration. And all the oral surgeons that have been involved with this say that there's zero potential for osteitis following the procedure. There's no potential for dry socket. And the reason for that, there's no blood clot that occurs. There's no disruption of tissue. It's an encapsulated treatment site. No open wound to get infected. We think that the possibility of infection is essentially non-existent, but we can't rule that out. But the key benefit for this, and this is what drives us, better lifelong outcomes. Our ideal outcome is that we mimic those patients that naturally don't form third molar tooth buds. No defects on the distal second molars, no chronic infections, all those issues. Now, the benefit for dentists is that it represents a new revenue opportunity. And I had a chance to ask a panel of oral surgeons about this who asked what happens when GPs start using this. And I asked a real simple question. When GPs like myself started placing implants, dental implants, did they see a fall off in the number of implant procedures in their own practices? Have they seen any fall off in implant production since GPs started placing? And they all said no. The reason that it'll be the case with this procedure is that many oral surgeons will want to offer this procedure. But more importantly, this will be a procedure that will open up the market. Parents don't want their kids to go through this. So it will open up the market. More people will get this procedure. A lot of people wait to have their wisdom teeth out, only to have problems later. And finally, this has all been designed for safety and predictability. We use power less than the power your cell phone transmits. There is no potential to damage or in any way interfere with the inferior alveolar nerve, the most common question we get. It just physically can't reach, even if we overablate by a factor of 100. It's just not enough power to reach down there. Now, our business model, and we had questions about cost. We're asking dentists to pay $350 per tooth bud treated. And that the surgical kit that we send out will have the disposable surgical guide, the disposable 3TBA handpiece, and then it will have the NFC card with the patient data on it. And that's everything you need to complete the procedure. The operator's responsibility is to ensure that the probe has access to the tooth bud. It may require an very short osteotomy using a 2 millimeter starter drill. But other than that, very simple puncture with the starter drill and then placement of the 3TBA handpiece. And our business model mimics as much as we can Align Technology in how they operated when they introduced Invisalign clear aligners to the dental market. And let's talk about the market size. It's really quite startling. In theory, the total addressable market is what consumers pay for having wisdom tooth extractions and to treat secondary problems. That's roughly $5 billion a year. The serviceable addressable market assumes that 50% of the kids are available for treatment age 6 to 12. And this translates to a market worth $2.5 billion for TriAgenics. And then you can imagine, based upon what the dentist upcharges, this could be a $10 to $12 billion market for general dentistry. Finally, critical measure, what we call our 7-year serviceable obtainable market. And it's a long phrase, but what we plan on reaching in terms of our revenues by year 7, we believe we will exceed $350 million in revenues with fully guided 3TBA, and that's TriAgenics revenues. So a little bit about TriAgenics, our traction and accomplishments. Our product development is complete. There is no research now. It's product development is done. The designs are frozen. We're scaling 3TBA into product manufacturing. We're working on our 510K application, and we expect to have first sales, if not late third quarter, for sure by fourth quarter of 2024. We have an amazing IP position. We have 25 US and international patents, and we think we own this market outright for sure in the North American continent. We have gotten notice that patents will be issuing in Europe. So the reaction on the part of dentists, we have anywhere from 5 to 10 dentists reaching out to TriAgenics daily, asking about availability and training. We have a large number of DSOs that have asked about this too. Now, our stock offering is what we call an equity crowdfunded offering. It's listed on Start Engine, and many of you may not be aware of crowdfunding, equity crowdfunding. This is not the same as the crowdfunding where people ask for donations. This is equity crowdfunding. We are offering a $4 million offering at $3 a share. And each stock offering that we've had has specific milestones, and that's to allow us to obtain 510K approval and reach first product sales. And use of proceeds, I'm currently the CEO of the company, but I'm smart enough to know that we need to hire a go-to-market CEO, and that search is going to start real quick. We will get somebody with dental industry experience. And finally, the major use of funds is manufacturing scale up. And I should comment personally as an investor that I'm not asking anybody to invest in this differently than I would. Pre-incorporation, I invested $1 million of my own capital to file for patent applications and complete initial prototype development. The ability to shape the zone of ablation and have a fixed center of ablation had to be solved before we brought any investors in. And I personally funded that myself. And then I conducted the initial animal studies at my cost. When TriAgenics was incorporated, after this technology development was completed, I invested $250,000 at $1 a share. And finally, on our Series A3 offering that's on Start Engine, the equity crowdfunded offering, I invested $100,000 at $3 a share. So I'm asking you to become a partner with me in the development. And a quick summary of our stock offering. And if you can see my mouse or my cursor, you can see our offering to date we're over, we are over 2.5 million. And our goal is to raise 4 million. We expect to close out the offering within 60 to 90 days. And people always ask, if you invest, what's your exit strategy? Well, my interests are aligned with all the shareholders. And so I would like to see the company go public or be acquired at a significantly higher price per share. We will be entering into what we call a Series B1 offering within the next 6 months, and that will be at a substantially higher price per share. We have had 2 companies who have knocked on our door wanting to know more about this, and there could be an acquisition potential there. But if I had to bet, I would say that we will be publicly traded in 3 to 4 years. So you have to be a patient investor for that to happen. My contact information, I urge you to reach out. You can go through our contact us page on TriAgenics.com, or you can email me directly. I'm easy to reach.
We have some questions, as you can imagine, Dr. Colby here.
Should we close this and just go full screen?
Sure. Yep, here we go. Okay, so there was some questions about the disposable guide. Are they custom? Are there different sizes? Could you sort of repeat that?
No, it's if you've placed an implant using an implant surgical guide, it's custom to the patient, and the stops on it are set for each tooth bud. They're patient specific. Now the probe itself can be used for 4 ablations, so it's not patient specific, but the guide itself will fit only the patient.
We have a question here about, do we have data on people that are not getting their 3rd molars removed prior to their 20s? I'm not sure if we have that data or not.
I've got this incredible library on 3rd molars, as you can imagine. And I'm not sure, the question is just vague enough. I'm not sure what the real question is, but what I can tell you is that when 3rd molars are removed prophylactically, in other words, around age 15 to 20, before problems develop, and there's the tissue around the tooth bud is submitted for pathology evaluation, almost 100% of the tooth buds show some degree of pathology. And I've got several documents on that I can send out. So there's a lot of data that shows that just because the teeth appear clinically to have no problems doesn't mean problems aren't developing. And the American Academy of Oral Maxillofacial Surgery has done a number of studies that demonstrate that to be the case.
Question about iTero scanner, is that sufficient for the 3rd molar area?
Yes, we can take any digital scan.
Okay.
Yeah.
Will this technology be used to remove tumors of the jaw?
That question is asked almost always by oral surgeons. So I'm impressed if the person who asked that was not an oral surgeon. And we have some very interesting discussions on that. Initially, the answer is no. In order to remove tumors of the jaw, that's an entirely separate R&D effort. It would have a different indication for use through the FDA and almost certainly require dynamic navigation. Now, I should mention, we've done studies with dynamic navigation, so we know it works just fine, but it would require dynamic navigation for that. A common question we get asked is, can you treat supernumerary teeth? And we believe we can. And again, that's a question asked by pediatric dentists, orthodontists, and oral surgeons.
Question here. So the site the laser goes in does not need any closure or post-operative care?
Correct.
Okay.
And It's not a laser. I want to be clear on that. It's a mechanical probe that emits microwave energy. And it's a puncture, and there is no suture. There's no cutting. It's a simple puncture.
Okay.
Yeah.
You state that you will charge $350 per site for the guide. What do you expect the surgeon will charge for the surgery per site?
I can't answer that legally. That would be a Federal Trade Commission violation, antitrust. But what I can tell you is that what I've heard, and that is most of the practitioners I've talked to would mark it up a factor of 2.5 to 3 times per treatment site. And the parents we've talked to will have indicated that they would happily pay that.
Another question here. This seems like an incredible tool when treating children with cleidocranial dysplasia. Any tests planned for these types of syndromes?
No, we have not considered that. We do know that once this goes to market, that we will work through oral surgeons and pediatric dentists to consider alternative applications like that. So, good question.
Comment here. We have a great presentation. I've been an investor since the last offering. I was happy to find this CE to learn more specifics on your progress. Can't wait to see this on the market soon. That's terrific.
Wow.
And let's see here. Recommended age for ablation. Could you go ahead and repeat that?
Yes. We have a very unusual database. We surveyed over 1,000 cone beam CT scans through orthodontic offices. And we actually measured the diameters of the tooth buds. And we measured for the presence of enamel formation. And the peak of the curve was about age 9 when we saw the most kids that had a tooth bud present with no mineralized tooth structure present. But the age range is 6 to, can start as early as 6, but that's unusual, and can go as late as 12. We will likely be recommending that screening started around age 7 or 8.
We have a question here. Who would determine the settings in the patient's cards?
Oh, TriAgenics determines that. The setting is the thermal dose, and we actually measure the largest diameter of it's a really important question. I didn't emphasize that enough. We will do just like we did on our animal studies, where we measure the largest diameter of the tooth bud. And then from there, we know our thermal dose. It's we've got those tables, and I should comment, that was the most expensive studies we did, was determining the thermal doses. And
I'm sorry, go ahead.
So that, and it's set as a function of time. So we don't change the power, we change the time. So bigger tooth buds have slightly longer ablation cycles, could be as long as 60 seconds.
A question here. You talked about 2.4 to 8 gigahertz. What is the frequency your unit will use?
We operate at 12 gigahertz, and I don't want to sound too techy, but we did a full spectrum scan. We considered RF ablation. We considered cryoablation. I mean, we looked at every form of tumor ablation imaginable. And we were technology agnostic. If cryoablation would work better, that's what we'd be demonstrating. At 12 gigahertz, a really interesting thing happens. The tissue, when you microwave in your, let's say chicken, in your microwave, the tissue starts to warm up. And as it warms up, the microwave does not penetrate as fast as the temperature increases. At 12 gigahertz, just the opposite happens. It appears that the tissue becomes more radiolucent, and we get this amazing uniform distribution of the thermal energy, which is why we keep the temperature down. It's a really important question. And we went up as high as 20 gigahertz.
Wow.
Yeah.
To get the stent, does a CBCT need to be submitted? Can provider print their own surgical stent?
At this point, we will only ship the handpiece with the surgical guide and the dosing card. And we know that that's probably the future, but at this point, we provide the kits.
Question here about what if at the age of 9, the second molar hasn't erupted yet? How do we address a case if the tooth bud is placed too close to the second molar? Can we anticipate any eruption variations of the second molar?
Well, we never saw a second molar that wasn't fully formed. And we never saw a third molar tooth bud that was adjacent to a second molar that wasn't fully formed, at least the crown. So if we saw a crown that was still forming, we would probably shy away from doing the procedure. Although the damage that it would cause to the adjacent tooth would be a disruption of the enamel formation, nothing more. So there could be the potential for an enamel defect. But again, we never saw anything close to that. The literature is very specific. If you see a third molar tooth bud, the second molar crown has been formed probably for 2 years. So we don't expect to see it.
Any contraindications to this type of treatment, such as history of cancer treatments, blood clotting issues? Also with children, isolation can be difficult, dry isolation can be difficult. Is this a factor that can contribute to complications when performing the procedure?
No, the only with respect to kids wiggling in the chair, and again, I saw the kids in our practice, and the surgical guide can move with the kid, and once you insert the probe, you can move with the kid, and isolation is not an issue here. It just doesn't come into play with respect to prior history of cancer or treatment. Not a problem. This is non-ionizing radiation. It's a purely thermal process. The FDA has a number of documents on this that's clearly state microwave does not cause cancer.
So we have one more question here. We're at the end of our session. This is, as a pediatric dentist and now investor, I believe that this will undoubtedly succeed. How can I stay updated on the progress of human trials?
Email me and I can keep you updated.
Yeah. Terrific. Well, we have had an exciting presentation, Dr. Colby, and it's such an honor to have you here this evening. And I know many of you have questions. Please reach out to Dr. Colby. His email is in both presentations, the last page. So if you don't have the course handouts, reach out to us. It will also be sent to you automatically when we close out. Anything you'd like to say, Dr. Colby, before we end?
It's really a pleasure and being here. And I really thank you for taking the time to hear about our development history and what we're working on. It's important.
It is important. And I am, again, very grateful to have you here this evening in TriAgenics, and we'll go ahead and tell everyone thank you and good night. Next screen, you will see the quiz for CE credit. It will also be emailed to you here in just a few minutes. Good night, everyone.
Thank you.
Thank you.